It's really a pleasure to be here. A little daunting to represent the healthcare sector, but anyway. So to talk about health in schools, integrating health and education, how do we really integrate? I'm a pediatrician. I love talking to middle schoolers about what they want to do in the future, their strengths. I love talking to them also about puberty, and I never have trouble talking to them and getting them engaged because they listen to every last word. But anyway, I have no disclosures. But as was already mentioned, education outcomes and health outcomes are really intertwined. They're highly interconnected, and we already know that higher educational attainment is associated with better health throughout the lifespan, lots of good evidence on that, and that healthier students, families, and communities have higher educational achievement. And we want to keep kids in school, ready to learn, and on that trajectory for a healthy adulthood. That's really our goal in pediatrics. But as we all know, we have shared goals, but we're pretty siloed. We're siloed financially. We have our FERPA, HIPAA issues. How do we really work together and really integrate? Not just co-locate, not just kind of keep each other informed, but really integrate because we do both have the best interests of the kids at heart. So in health, we really feel like we should be going to where the kids are in school and keeping them in school, not necessarily having their parents always take time off of work and take the child out of school to come and see us. How do we really get out of our silos and keep kids in school? We also know that children these days are facing a lot of adversities. And this is the Adverse Childhood Experiences Study, the largest public health study you never heard of, according to Huffington Post. And as you know, this is the study that the CDC and Kaiser study that really looked at the link between adverse childhood experiences and adult chronic conditions. They really highlighted that too many of our children do face adverse childhood experiences, whether they be poverty or living in families where there are mental health problems or problems with violence, whether it be incarcerated parents, families that have faced discrimination, many adversities that children are facing, and over half of our children are facing at least one of those adversities, and many of them many adversities. So this ACEs study really looked at the association between childhood stressors and adult health, looking at 17,000 adults and surveyed them on their past history of these adverse childhood experiences. And you don't have to read all of this, but it basically shows you there's a dose-response relationship. As a person has more adverse childhood experiences, their risk for poorer adult health increases. And that is true whether it is for ischemic heart disease, for lung problems, for sexually transmitted disease. You see this nice dose-response relationship. You can see the same thing if you look at mental health outcomes of depression or anxiety, and you see the same thing for absenteeism, financial problems, and job problems related to work performance. I think there's plenty of evidence now that shows that child health is really the foundation for adult health, and these adversities do affect adult chronic conditions, and we need to be focusing on that. We do know from the World Health Organization probably that the single most effective way to improve health and reduce disparities is to invest in helping young people reach their full academic potential. So how do we go about doing this? There is lots of data out there on school-based health centers, and we just heard about the effectiveness of school-based health centers. This is one review that looked at 44 studies on school-based health centers showing that they can increase recommended preventive services like immunizations in kids, strong evidence there, that it can improve asthma, again, strong evidence, that it can improve physical health, though maybe not self-reported physical health. Mental health, we need to still do a lot of work on. I think it's hard there as far as what our measures are, but I think that we are all really recognizing that we can do more with mental health, and lots of middle schoolers are facing mental health issues. Reproductive health, there is evidence that increased contraception through school-based health centers does occur. Whether it changes sexual activity, not as much evidence there. We know that also other risk behaviors, smoking, substance use, school-based health centers have an impact, and there has been demonstration of improved educational outcomes just from having school-based health centers. We wanted to have school-based health centers in all the schools, but also go beyond that and really how do we even do more as far as wellness in schools and have school-based health centers, but even do more. So the Rales Center for the Integration of Health and Education was formed about 5 years ago with the goal of really weaving health into the fabric of learning and to really improve the health, education, and future productivity of children by really integrating. Again, not co-located, but integrating in many different areas. Our focus is on academic achievement in health, and those are our outcomes. And we do have a full-service school clinics in 2 KIPP schools with over 1,500 kids. We also feel that the school population is really the population we're focusing on, so we have wellness programs and screening programs for hearing, vision, BMI, dental, for all kids, and also school health campaigns. We have chronic illness programs, which I'll mention a little bit more in a minute. Nutrition and physical activity programs, getting a salad bar was a big success. School health curriculum, where we've introduced mindfulness-based stress reduction, have a transition to middle school program, including violence prevention and parent involvement, and reproductive health education. And then we do also focus on the parents and the teachers, recognizing that if they are not healthy and well, that they can't support their kids. So we have programs specifically for parents and teachers as well. So let me tell you about a couple of our specific areas of success. One is about asthma. And let me tell you about Darnell. He's a 6th grader with asthma. It's the first month of the school year. He's already missed school 3 times. He seems out of breath when he comes back from gym class and his teacher sends him to the Rales Health Center. Nurse Catherine listens to his lungs, checks his breathing and oxygen level. He has some mild wheezing, complains of some chest tightness, but there's not an inhaler or a physician's order on file for him. So Nurse Catherine calls his mother, who says Darnell has had severe asthma since he was in preschool. He always has flare-ups in the fall and has been in the hospital a few times. They have a hard time getting to the doctor for checkups because of mom's work schedule. She's worried that if she takes off more time from work, that she's going to lose her job. Darnell often forgets to take his daily controller prevention medication because his parents have to leave work early. And Nurse Catherine offers Darnell's mother an appointment with the nurse practitioner who sees Darnell, offers a treatment, orders refills on his medications, which are delivered to the school. She writes an order for Darnell to get his daily asthma preventive medication in school every morning, and Darnell and his mother receive education about asthma medicines and how to use a spacer with his inhaler. Nurse Catherine refers the family to the Baltimore Asthma Program so they can do a home visit to look at his asthma triggers, and the nurse practitioner calls the pediatrician to discuss ongoing care for Darnell. Now Darnell comes to the Rales Health Center each morning along with about 50 other of his classmates for a puff of his controller preventive medication. He hasn't had an asthma attack since the first month of school and hasn't missed any more days. He loves sports, but avoided participation because he was afraid he might have an asthma attack. But he's now part of the Rales after-school exercise class and took part in our annual 5K fun run with his family and couldn't believe he made it 3.1 miles. So this is just an example of directly observed treatment, preventative treatment of asthma that has had an impact for many kids. The second program I wanted to mention is our vision program, and we all know that you can't learn if you can't see. We have a program where we screen all the kids in the school for visual acuity, but it doesn't stop there. We don't just send a note home saying go and see a doctor. We bring in the optometrists who do check their eyes and do the prescription for glasses, and then we fit them for 2 pairs of glasses, one for school and one for home. And this is our first 100 kids that needed glasses. As you can see, many of them were previously told that they needed glasses, and some of them had actually worn glasses, but only 28 of them have glasses, and then only 17 of them actually have glasses in school, and some of them aren't wearing their glasses in school. I've had kids with glasses, and I know they get lost, they get broken. So we have initiated this program, given them 2 pairs of glasses, worked with the teachers on who's supposed to wear their glasses and where do they keep their glasses, and we know that this has had an effect on kids' ability to learn. One of our principals said that the Rales program allows me to focus on education, which is what I'm supposed to be doing, and that the vision program is the closest thing to an education miracle that I've seen. So this is one of our happy customers. So as far as outcomes, at Hopkins we measure just about everything we do, and we have demonstrated reduced chronic absenteeism, 49% drop for children with asthma, 50% drop for children with ADHD. We've been able to reduce emergency department utilization, increased immunization rates, screened most kids for vision, dental, BMI, and we've been able to demonstrate cost effectiveness. Despite higher staffing costs, every dollar invested in the Rail Center returns more than $4.20 of social benefit. And finally, kids, parents, and teachers really love the program because they feel like that it's really convenient for them and it is improving the health of their kids. I would just finish by saying that healthcare really is focused more on cost these days, and as a result, really focused on how do we make sure that kids stay out of the hospital. Healthcare is increasingly looking at social determinants of health and are interested in programs like this to keep kids out of the hospital. I think working together we can really improve health and educational outcome for all kids, and I'm hoping healthcare will be more involved in that as healthcare moves along. So, thanks.
Next, we're going to hear from 2 people in the social work sector that work directly with middle schools. The first is Mariam Touloui, who is the director of the Holistic Social Emotional Support Unit at the Oakland Unity Middle School. Then we'll be hearing from Evelyn Garcia, who's the school site social worker and field instructor at the Will Rogers Middle School, and that's a part of the Lawndale Elementary School District. So, the social worker sector.